All right, well, good morning, everybody. For those of you that I didn't meet yesterday, my name is Julie McIntosh, and I'm the community educator with CompassionCare Hospice. I know a few of you, we kind of chuckled at the table. I always like to say, we hope you don't need our services for a long time to come. Some of you yesterday made comments like, oh, I hope I never need you. I'm going to challenge that today, hopefully, by the time you leave here as a nurse with over 20 years experience and working with people at end of life. My belief is that everybody who's facing an end of life illness should have hospice support, and I hope you'll feel that way too after hearing this. Now, you may not need us for a long time, but you may know somebody who does. We talked with people yesterday who have parents that are ailing, siblings, spouses, a neighbor that they're concerned about. So we hope you'll get some information from this. We know that hospice can be kind of a scary word. People sometimes when we go to health fairs, they'll walk by the booth and they go, don't even look at me, like I might catch something. Hopefully you'll find out that it's really nothing to be scared of. There's a lot of myths and misconceptions, and that's our goal today, to wipe those out so you really know what is hospice. This is a wonderful benefit that you guys have all earned. How does it help? How does it bring support? I have probably worked with personally over 200 families going through this process, and I've never had a family say to me after their loved one passed, I wish I wouldn't have done this. What we hear all the time instead is, I wish I would have known sooner. Mom only was able to get hospice support the last month of her life. Had I known that she could have had this support for 6 months or a year or longer, oh my goodness, what a difference it would have made. So we hope you'll walk away today with a totally different understanding and appreciation for what hospice is. So we're gonna start with kind of a funny question. How many of you here believe that you are going to die? Right? Not today, hopefully not any time in the near future, but can we all agree that 100% of us in this room, we're going to pass away at some point. It is part of living. It's part of the life cycle. In our culture, especially in the United States, we don't like to talk about death. We don't want to talk about our own mortality. And we've made great advances in medical science, right? We can cure people of a lot of things, and we can keep people alive much longer than we used to. However, at some point, all of us are going to come to the end of life journey. And so it's important to know, what are your options? It's important to have those tough discussions with people in your life. What are your wishes? There are huge research studies that have been done. 90% of people, if they're asked, we don't want to pass away and spend the last days of our life in a hospital, in an ICU bed, hooked up to machines. Most people, if you ask them, they say, well, when I get to that point, I want to be at home. I want to be surrounded by people that love me. I want to be comfortable. I want to have a support system. That's what hospice is. Okay, so you guys have these handouts here. We're going to go through these handouts, so feel free to follow along. If you can't tell already, I'm very informal. I'm not your standard lecturer or instructor, so please feel free as we're going. If you have questions, put your hand up, stop me, shout out, dance on the table. Well, don't dance on the table. If anybody fell and broke a hip, I would never forgive myself. So no dancing on the tables allowed. On your first slide, we've kind of, again, tried to make this a little bit funny. This is really a visualization. When most people think of hospice, what do they think of? They think of kind of the grim reaper. They think of death. They think of somebody who's lying in a bed, barely conscious, they're not able to eat, they can't swallow, they can't take medications anymore. They're in those last hours of life. And we're going to challenge that today. You'll notice when you see our brochure, we say, let's talk about hospice, let's talk about living, because it really is about living with a life-limiting illness, okay? So on the bottom slide, it shows what actual hospice patients look like. We have patients on hospice, especially here in Las Vegas, that go to the casino multiple times per week. They go on outings. They go to dances. They're out shopping. Just because somebody's receiving hospice support does not mean that they're bedbound and they're to the point where they're in the final days of life. I always laugh, I'm not sure Nicole put this presentation together, I'm not sure why there's the cute doctor and nurse. I think all of our nurses and doctors are pretty cute, but I'm not sure that can be guaranteed with hospice support, but you get a wonderful support group around you. We have traveling patients. You know, if you're dealing with a life-limiting illness and you know that you're in those end stages of life, wouldn't you want to fulfill your bucket list? What are the things you've always wanted to do? Where are the places you want to go? So especially, again, being in Las Vegas, we have 2 traveling patients just this week who are from out of state, and while they're here in Las Vegas, we become their adopted hospice in case they have an emergency, in case they need anything. But being on hospice does not limit what you can do in your involvement. If anything, it gives you the freedom. What is most important to you? We know that we've got a condition that we're dealing with that isn't going to get better. We kind of have to face our mortality, and we know what are the things that are important, what do we want to do. So it's really focusing on quality of life over quantity, okay? So when we talk about hospice, what is hospice? Hospice is actually a concept of care. It's not a place, and a lot of people, that's one of the big misconceptions. We think hospice is a place that people go to die. It's really a concept of care that, you know, traditional medicine, we focus on aggressive curative treatment, right? If we have an upper respiratory infection, it's turning into something like bronchitis or pneumonia, we go to the doctor, we get antibiotics, and we get cured. So most Western medicine is focused on aggressive treatment. How are we going to cure this illness? But when we're dealing with chronic illnesses that have gotten to advanced stages, we are shifting our focus from aggressive treatment. We know we may not be able to cure this illness to what we call comfort or palliative care. You might have heard that term. It's becoming more and more popular, palliative. It means we're focusing on comfort. We want to control symptoms. We don't want people to be in pain. We don't want people to be anxious. If they have lung issues and they're having difficulty breathing, we want to make sure those symptoms are managed, again, so that you can focus on having the best quality of life that you can have. So it's a shift of focus from aggressive curative medicine to palliative comfort care. It's a concept of care that can be provided anywhere you call home. So you guys live here in this beautiful community. The goal is that home hospice comes to you and allows you to remain in your home, to remain as independent as possible for as long as you can. That's always our goal. And we're going to talk, there are some different levels of care, but hospice is not a place. Hospice comes to you. We take care of people that are in private homes. We take care of people that are in assisted living. I know yesterday many of you are familiar with the assisted living just up the street on Deer Springs. A lot of you volunteer there. We talked with you. We have our patients that live in assisted living. We have patients that live in group homes. We even have patients that are living in skilled nursing facilities. That's kind of what we used to call nursing homes. So hospice can join and be part of the team no matter where you live. So anywhere you call home. It also, where traditional medicine, we're looking at treating a specific disease, a specific illness. Hospice care is really more holistic. We're looking at the body, soul, mind. You know, it's that whole, we're looking at the spiritual, the emotional aspects of dealing with a life-limiting illness. So we're not treating just the disease and what's going on medically and physically in your body. We're treating the entire person. So as we'll talk about, there's spiritual support, there's volunteer support, there's bereavement support. And then it's also not just limited to the patient. Most of you know if you go to the doctor is concerned with you and what's going on with you. For hospice, the patient and their entire family or support system, and that could be a spouse, it could be an adult child, it could be a paid caregiver that's coming into the home. Like I said, in assisted livings, they have caregivers there 24 hours a day. Those caregivers become your extended family. So whoever's involved in taking care of the patient, they become our client as well. And the support services that we're going to talk about today are available to them as well as the patient. So as I said, lots of misconceptions about hospice. So we're going to go over some of the most common ones that we hear. The first one, and we've already touched on, hospice is a place that you go. Remember, hospice is not a place, it's a concept of care. Hospice patients are doped up on medication. We've all kind of heard that when you're on hospice, we're very concerned with pain and controlling pain, and that's true. And hospice doctors, hospice nurses are specialized. They have lots of education on taking care of someone's pain. And we're concerned with that, but we never want somebody to be doped up. Again, we focus on quality of life. If you're on so many medications that you can't do the things that you enjoy, you can't get out to the casino, you can't go out shopping or go see a show, then we have a problem. So the hospice team works very closely with the patient and their family to make sure that the pain is managed, but the person is not overly sedated. So yes, we're concerned about pain control, but our goal is never to have somebody doped up. Another one is that all medications are stopped except pain medications. And that's not true either. We might be taking care of somebody who has an end-stage lung disease, but they also have high blood pressure. We are going to treat that high blood pressure because if that gets out of control, you're not going to be comfortable. You're going to be uncomfortable. You're going to have physical symptoms. It's not good for your health. We want to make sure that you stay as stable as possible. We're not aggressively treating the disease, but we want to make sure that your entire body is taken care of. So if you need medications for blood pressure or thyroid, or you've had a previous stroke and you need those, again, the hospice team works together with you, with your family, to decide what medications are medically necessary. The next one is that if you sign up for hospice, you'll pass away quicker. A lot of people feel like if I sign on that dotted line, it's like a magical, signing my own death certificate. And actually the opposite is true. They've done major research studies that people who receive hospice support actually live longer than those who don't. Why do you guys think that is? Any ideas?
Probably relieve pain and things like that, where they're more comfortable and they don't want to give up.
Absolutely. So she said, because their pain is being relieved and being managed, they're not as uncomfortable, they're not looking to give up, they have more hope, right? Absolutely. You have this whole team, as we'll talk about, of people around you. You have more eyes on you, more hands, more people watching out. We can be more proactive. If we start seeing signs that somebody might have the beginnings of a respiratory infection or a urinary tract infection, we can treat it right away. We've got people, touching base with you constantly throughout the week, and any changes, we can be very proactive. So yes, absolutely. People tend to actually live longer with hospice support than without. Another common one that we hear is that hospice is only for people with cancer. Cancer patients certainly can receive hospice support, but as we'll talk about, there are no disease restrictions. This is a Medicare benefit, as we'll talk about. Medicare says it's not about your diagnosis or what your disease is, it's about prognosis and what's going on with you. So we look at the big picture of where your disease processes are to look at that. And so some of the common ones, obviously we do see patients with cancer, people with end-stage heart disease, people with end-stage lung diseases, kidney disease, liver, Alzheimer's and dementia. We see a lot of patients that because of that, they've gotten to the point where they need that hospice support. Parkinson's is another one. So there is no specific disease that you have to have. Medicare says, again, we have to kind of collect the data and paint a picture, but it's not one specific disease. Hospice means you're giving up. Hopefully I've already told you a little bit enough to make you understand it's not about giving up. It's actually about shifting our focus to quality of life. What do we want to do in the time that we have left, however long that may be, to focus on quality of life? Many patients that we talk to, they don't want to go in and out of the hospital. They typically, they've been in the hospital 3 times in the previous months. They're going back and forth to the doctors. They're running tests. They're keeping them in the hospital. They don't want that. They want to be at home and have the medical care come to them. They're not giving up. It's just a shift of focus to accepting where we're at in the disease process and saying, now I want to focus on quality of life. And then the last one is that you can live in a hospice house. I'm going to talk to you a little bit about what we call levels of care. And when we do, you'll hear a little bit about inpatient care. But again, hospice is not a place you go. Although there is some inpatient care that can be provided for a very short period of time, you don't go live at the hospice. You still live at home or in an assisted living or in a group home, and we can help with that. If somebody needs to or wants to find different placement, we have an entire team who's going to help make that happen. But if your goal is to remain at home in your house independent, we're going to work with you to bring those resources so that you can do that. Okay? So those are some of the common misconceptions. Does anybody have others maybe that you've heard or thought about hospice that you'd like to share? No? Okay. We'll go on then. Oh, go ahead. And we're going to talk about what makes you eligible for hospice care. And so that one, yes and no. She said she's heard that when a physician can refer you to hospice care, it means you have 6 months left. And we're going to talk about that. There's a little bit that's somewhat true and somewhat not. So give me just a moment and hopefully I'll answer that question for you, but that's another common one.
I understood that you only can go to assisted living, you have to be able to help yourself. And that's the only way you can stay there.
Well, and I can answer this. I actually, for 5 years, I was the nurse at a large assisted living here in town. Typically with assisted living, we want you to be able to age in place. There are caregivers there that can help with your activities of daily living. So things like bathing, dressing, getting in and out of the bathroom, toileting, those kind of things. But you have to be able typically to participate at some level. Even if you need a caregiver to help get you out of bed and into a wheelchair and bring you to the dining room in the wheelchair, you can't be typically completely bedbound. However, sometimes we have people that have lived at assisted living for years. They get to the point, in their final days, and then they can remain. They can file what's called a hospice waiver, and the state can allow them to stay because they have the medical support coming in to help take care of them as well. Okay, did that answer your question?
Does that cost more? The more care you need,
typically,
it costs more money?
yeah, she's asking, does it cost more? Typically with assisted living and group homes, the more care you need in your daily activities, the more that you pay. They have what they call levels of care. Yes. Nope, okay. So our next slide is who's eligible for hospice care. Anyone who's been diagnosed by a doctor with having a life-limiting illness. We used to say terminal illness. You're probably more familiar with that term. I don't think it's really politically correct anymore, so we've started saying life-limiting illness. I think it sounds nicer, but we're talking about the same thing. We're talking about someone who's been diagnosed with a condition that the doctors are now saying, we can't cure this condition, like unfortunately Alzheimer's. There is no cure for Alzheimer's, so when it gets to the more advanced stages, then somebody may qualify for hospice support depending on what's going on with them. Anybody can make a referral to hospice. So your question that you had about when the doctor, sends you to hospice, sometimes doctors do. You might speak with a doctor either in the hospital or your primary care doctor, and he might recommend, maybe it's time to start thinking about hospice. But our hope is that, by doing education like this, you guys will know if you get to a point and somebody needs hospice, anybody can call. It's a little bit different than some of the other things like with home health. Home health, they have to have a doctor's order in hand before they can even speak to you. A doctor has to order it. It's not the same with hospice. Anybody can make the referral. So if you called us and said, I'm interested, I think I have a parent who would really qualify, and would benefit from this, we could come out and evaluate them, look at what's going on with them and see if they meet the Medicare criteria. And if they do, then we take that responsibility and we can reach out to the primary care doctor or the cardiologist. Sometimes we get calls from families and their loved ones in the hospital. The doctor hasn't written the order yet, but they want more information. And then we can reach out to the doctor in the hospital and say, we've spoken to the family, they meet criteria, we would like you to write an order. But even sometimes, we'll have some primary care doctors who say, well, I haven't seen him in a really long time. I want him to come into the office. Or somebody doesn't have a primary care doctor. Las Vegas is very transient. Sometimes we talk with people who've moved here, they've been here a year, they haven't gotten established with a doctor. We can get that doctor's order for you. So that's something that we worry about. You don't have to worry about that. So anybody can call and say, I'd like more information. Or again, if it's somebody that you know, you can say, you know, I've talked to them, they would like to meet with you, can you come out and meet with us? And then someone like myself or someone from our team would come out and again thoroughly explain what is hospice, look at everything that's going on, and then if everybody's in agreement and they want to move forward, we'll take the steps to make that happen. And it's a very simple process. There are times we go out and meet with a family, and within an hour or two we have everything in order and that person's starting to receive services. So it's not something that takes days or weeks or months to do. It can be a very quick process. Okay, did I answer your question? Okay, good.
We moved 25 years ago.
You know, hospice has been around since about 1967, so it's not a new concept. I think it's gone through some changes and it's evolved as it's grown, but it's been around. It started in England in 1967, so it's been around in our country for a long time, but there are so many people that just don't know. Even people in the medical profession, we talk to doctors, nurses, social workers all the time, and they go, oh, I knew hospice was for people that were dying, but I didn't realize there's so much more to it. So that's our goal with doing this education. So the big question we get, sometimes we do talks like this and people go, okay, everything you explained sounds really great, I love it, but how much is it going to cost? So here's the beauty of it, it doesn't cost a thing. This is a Medicare benefit that you have earned. If you have Medicare A covers hospice, Medicaid also covers hospice. It is also a VA benefit. If you're a veteran, VA benefits cover it. Almost all of the commercial insurances, if you don't yet have Medicare, cover it. And then many hospices and CompassionCare does this all the time. We take cases regardless of someone's ability to pay. We get calls all the time. You guys know we have a county hospital here that sometimes takes care of people that aren't citizens. They're down on their luck. They may not even have a home. And we take those cases often because nobody should die without this support. So if somebody needs us, we're going to be there for them.
If you give up Medicaid, Medicare, and you say that Humana, senior dimensions, are those?
That's a good question. She's asking, what if you've given up Medicare and you have what we call a Medicare Advantage plan, such as Humana, Senior Dimensions, CareMore, those all fall under the same category. You still have Medicare. What you've done is you're agreeing to use their contracted doctors, their hospital, their lab, but if you are eligible and you receive hospice support, if you choose to receive that, it reverts back to your strict Medicare A. You can go with any hospice. I will tell you, some of these managed cares do have their own hospices, and sometimes they like to not give as much information, and so they'll say, well, we have a hospice and you can use our hospice and you don't have any choice. That is not true. It is 100% a Medicare A, and it doesn't matter what Medicare Advantage plan you have. You should talk with multiple hospices. You should meet with them. Find out what makes them different and special. Find out, you know, how long they've been in town, how long have they been caring for people, what's their reputation. And you can use any hospice that you choose. Okay?
What's the length of time Medicare will pay for that?
That's a great question. If you guys couldn't hear, he's asking what's the length of time that Medicare will pay for somebody to be on hospice support. It's a great question. There is no time restriction. So as we talked about, we say that somebody has to be certified with a life-limiting illness. And what we say typically is that somebody has to, we have to think that their disease process, if it ran its natural course, they have 6 months or less to live. However, we know that people don't come with an expiration date stamped on the bottom of their foot, do they? And as I said, sometimes people get hospice support and they actually do better and they live longer. So Medicare says there is no disease restriction and there is no time restriction. So we have had patients on service for 6 months, a year, 18 months, 2 years, Nicole, probably even longer than that in some cases. Again, it's a government benefit, so Medicare does have guidelines. We recertify, and every hospice does this. We recertify, and the team meets with you to make sure, do you still meet the criteria? And as long as you do, it is unlimited. You can receive hospice support for an unlimited amount of time. And here's another question that's kind of closely related to that. Hospice is not a one-time benefit. Sometimes somebody might have lung disease. It's this time of year, we see a lot of respiratory infection going around. They end up with pneumonia. They end up in the hospital. They qualify for hospice support. They choose hospice, and in 3 months, they start doing a lot better with all that extra care and support and being watched over really closely. They recover from their pneumonia, and they're actually doing really good. They get signed off hospice. We say, you know what, you're doing so good, you don't need us anymore. Then they revert back to whatever they were before. So if you had managed care like CareMore, you would revert back to your CareMore or your Humana or regular Medicare. You go back to seeing your regular doctors. And then if you need us again, maybe 6 months down the road, a year, 2 years, 3 years down the road, something else happens and you need hospice support again, it doesn't go away. You don't use the benefit up. So you can come on and off of hospice, and that's something that most people are very surprised to hear. Go ahead.
How often do you recertify?
It's 90 days. So after you initially come on, their first 2 certification periods are at the end of each 90-day period. Thereafter, it's 60 days. So every 60 days, as long as you're on service, you'll be recertified to make sure that you still meet that criteria.
And what about, let's say you're on hospice and you break a leg and you have to go to the hospital. Does hospice start and then start up again when you get home again?
That's a great question. And for those of you who couldn't hear, she said, what if you're on hospice, but then you fall and break a leg? And you know, sometimes that happens, or someone falls and they need stitches and they have to go to the emergency room. If you go to an emergency room and you're not admitted and you return back home, hospice does not have to be interrupted. If you go into the hospital and you're admitted and have to stay in the hospital, then yes. Again, Medicare says we're not going to pay for hospice and hospitalization at the same time. So there's one form that you sign so you can revoke hospice. You revert back to your regular Medicare while you're in the hospital, and then as soon as you come out and you're being discharged back to home, we would come out, get everything in place, and you'd be back on service again if that was your desire.
Because you don't have to reapply, is that what you're saying?
Well, we have to come out, again, it's government, so there's a few consent forms and things we have to fill out and sign, but it's a very simple process, and then we would start service again. Yeah, so that does happen. Now with most things, of course, we don't want you to have to go in and out to the hospital. Our nurse would come to you. So if you weren't feeling well or someone had a fall or something was going on, we have nursing staff 24 hours a day. So when it's not your regular nurse, there's an on-call nurse. They'll come out to see you if they need to. So our goal is that you don't have to go to the hospital. But again, in a situation like that, if you have to go to the hospital and have that leg put in a cast, of course, and then we would stop hospice services for that period of time and we would start them again when you're home. Okay? Nicole, that's a good question. Is there a limit on how many times if somebody had to go into a hospital or had a situation where they could be signed off and signed back on?
No, if it's medically necessary, there's no limit.
Okay. Good questions.
Go back into, say, your HMO. Do you have to reapply for the HMO or just automatically say no?
Automatically. What happens is it kind of sits in the background. You know, you don't pay anything for your Medicare Advantage plan. Medicare pays them. You're agreeing to use their doctors, their facilities. Medicare pays them when you do that. So when you're under hospice, they're paying hospice, not the managed care. But then, yeah, and we would coordinate that. So when we do have people that they're doing so well, they don't need our services anymore, we don't just say, okay, you're doing really good, bye. We work with you and we let you know, in plenty of advance notice, and we help you get reconnected with your managed care or your primary care doctor. We make sure that you have enough medications because we know you may not get out to see your doctor. So we make sure that everything's in place before we say goodbye. Another question.
What happens if, say, you're visiting your son or daughter or something, it happens, and can you get it in another state? How many states are you in?
That's a great question. She's asking, what if you are visiting and you go out of state, what happens? We are local. We've been in Las Vegas for 10 years and we service Clark County, but we will set you up. If you'll work with your team and you'll let them know, I'm going to Montana for a week to go visit my son. We will find you a hospice in Montana that will become like your adopted hospice. And if you have any kind of emergency or you need to be seen or you need supplies or medications or anything while you're gone, they'll be kind of your adopted hospice until you return home. And we arrange all of that for you. Okay, good questions, you guys. So everything is covered 100% under Medicare or some of those other things that we talked about. There's never an out-of-pocket cost to you. So what's included in that one? It covers 100% of what? Your next slide talks about what it includes. You're assigned a doctor, a medical director who's assigned to your case. Within your first 2 weeks of starting service, that doctor is going to come out and see you in your home so that you guys can talk. You can make sure that everybody's in agreement on the plan of care. You have an RN who we call a case manager who becomes your RN. She's going to see you. Typically, it's between 1 and 3 times a week, depending on the need. If there's need and she has to be out every day, that will happen. Typically on routine care, though, it's between 1 and 3 times. There's also another nurse called an LPN, a licensed practical nurse like myself, who's going to partner with that RN case manager, and she may see you on other days of the week. So she may come out in between those RN visits, and she's part of your team as well. A certified nursing assistant, or CNA, is going to come out. A lot of times they're providing personal hygiene, bathing, dressing support, skin care. That team works very closely together, so one day if the CNA is there and she sees that something's going on, she can alert the LPN and the RN who can make a special visit. So that team are going to see you throughout the week. That CNA can be anywhere from 3 days a week up to 7 days a week if there's a need. Sometimes we have patients that they need that CNA to come out every day, and if that's necessary, that can happen. A social worker. Oh, I'm sorry, there's a question. Sometimes she's asking when would we have a CNA go out every day. Sometimes it's because of the caregiver situation. You know, the person who's taking care of them maybe is also frail and is not able to do as much. Sometimes it's because there's more medically complicated things, like if somebody has a feeding tube or a Foley catheter, something that needs that medical attention on a daily basis, then the CNA will come every day. Normally it's 3 to 5 times a week, but again, it can be every day if it's necessary. A medical social worker is going to be assigned to your case and is also going to see you within, I think it's within the first 3 days when you start service, and then, you know, at least every 2 weeks. That's someone who's going to work with you on a whole myriad of things. It can be end-of-life planning, getting your affairs in order. Sometimes, you know, we have difficult family dynamics, things that need to be resolved. The social worker gets involved with that. If we need placement, you know, sometimes we have somebody that was living completely independently and they just don't feel comfortable even with the hospice support. They're looking at moving to an assisted living or a group home. The social worker is going to help arrange that, help you find the right place, a place that you and your family are happy and comfortable with, that's in your price range. So the social worker does a whole myriad of different things to help you throughout your case. Spiritual support, we have chaplains. There are also priests and rabbis. Sometimes people will say, well, I'm not very religious, I don't need spiritual support. The chaplains do so much more than that. They're really there to visit with you, to get to know you, to do what we call a life inventory. It's important if we're looking at the end of our life, sometimes we need to do that inventory and be able to make peace with our life and where we've been, what's coming ahead. So that chaplain support is also available, and they'll come out to see you, you know, weekly if you would like that. There's bereavement support. We have a wonderful bereavement coordinator at our company, Kelly. She's fabulous. That bereavement support is available again for the patient and the entire family. Sometimes, you know, we're dealing with a parent and it's hard. Maybe one of the siblings isn't quite ready yet to let go and they're in a little bit of denial. So that bereavement support is really important to help people understand where they're at. What is the future going to look like? Where are we at on the journey? How can we prepare? And one of the beautiful things about hospice is that support does not end when the patient passes away. That bereavement support is available for 13 months after the death of a loved one. So we stay in contact with the family, with the loved ones, with the spouse, to see how they're doing, to see if they need anything. We help them with final arrangements. We're actually having a beautiful memorial service. We do it every year. It's coming up in April at the Springs Preserve, where not only our families and people, you know, that have loved and known our patients, but anyone in the community can come, and it's a beautiful ceremony to honor those people that we've lost this year. So that bereavement support. Finally, if that's not enough, volunteer support. Every hospice works with wonderful volunteers, and we talked with many of you yesterday and you were interested in that. You know, a lot of you took our flyer. Volunteers can do, again, a whole bunch of different things. Some volunteers don't want to work with patients and they come in the office and they help do office work. Some volunteers want to go out and visit someone in their home and they'll go out once a week, twice a month, they'll go visit. Some people say, you know what, I want to read to somebody. I really love reading. I want to go read the Bible to somebody. I talked with someone yesterday who said they're a music therapist. Is that you? That's right, I thought I recognized you. What a wonderful gift if you're willing to share that talent and go out to a group home or an assisted living and do some sing-alongs and some music therapy. It's not just for our patients, but for everybody there in the community. So volunteers can do wonderful things. A lot of times if we have you know, a husband and wife, you know, the husband's on service, the wife needs to go out, she needs to get her hair done, or she needs to go to church, or she just needs some time away. That volunteer can come and visit with the husband, stay with him for a couple of hours so that she can get out of the house. So all of that is your team when you have hospice of the support, as well as all of your medications. So remember we talked about the hospice doctor, the nurse, they're all going to work with you to decide what medications are important, what's medically necessary. All of those medications then are covered 100%. And not only that, I love this part, they're delivered right to your door. So you don't even have to go to the pharmacy anymore. The driver brings them to you and he delivers your medications. Medical equipment, somebody might need an adjustable bed, like a hospital bed. They might need a wheelchair. They might need oxygen or portable oxygen or an oxygen concentrator. They might need a bedside commode or a walker. All of that medical equipment is also covered 100%. And then medical supplies, incontinent care supplies, so briefs and wipes and gloves. If you have wound care that needs to be done, all of those supplies are covered 100% as well. And then finally, transportation. Now this isn't transportation to Aliante Casino, but this would be, you know, if we have somebody who's in the hospital and they're ready to come back home, we would arrange for transportation, get them home, get all the equipment delivered, get them all set up. Our nurse is waiting for them when they get home. Okay, so all of that is what's included and that's all covered 100%. We talked briefly that there are different levels of care, so I'm going to explain to you there's 4 levels of care that Medicare has set out that all hospices should provide. The first one is routine care, and that's what we were just talking about, where the nurse comes to see you 1 to 3 times a week, the LPN, the CNA, the chaplain. You're in your home, wherever home may be, you're fairly stable. That's routine care. The next one is called continuous care. This might be for somebody who's having uncontrolled symptoms. All of a sudden we're in a crisis situation and they have pain that can't be controlled, or nausea, or agitation that can't be controlled, and anxiety. We have a specialized program. We're the only hospice in Las Vegas that does. We call it crisis care. We have a dedicated team of nurses that are on call 24 hours a day. If we run into a crisis situation, we put a nurse at the bedside, usually for a minimum of 24 hours, but until that crisis passes. And that's a huge benefit. Even if there is a caregiver in the home, to have that nurse at bedside, adjusting medications, providing all care until we get those symptoms managed. And that's called crisis care. And I've seen cases go on for 5, 7, 9 days. If it's needed, we're going to stay there at the bedside. And we do that because we know most patients want to stay at home. They don't want to go to a facility, to a hospital, or what we call an inpatient unit. They want to stay home. So we've decided to dedicate a team to do just that.
Kind of address the caregiver breakdown, like if someone's been up several hours, days.
That's a great, Nicole's saying one of the reasons that we can initiate crisis care is when there's caregiver breakdown. Sometimes, you know, we take a loved one home from the hospital, we're, you know, certain that we can do it, we can take care of it, and then it becomes overwhelming. Maybe we're not sure how to provide the medical care, or maybe the patient all of a sudden is going through a rough period and they're awake constantly and that caregiver can't even get any sleep. So we can put a nurse at the bedside for those situations too, to provide education, teach the caregiver how to provide that care, and be there with you until you feel comfortable. The next level of care is what we call general inpatient. And this, I think, is where people get that misconception that you go to live at a hospice. Some hospice companies have a freestanding building that they call an inpatient unit, or sometimes you'll hear it referred to as an IPU. And what they're doing is, just like we do crisis care and we put a nurse at bedside, if somebody's having symptoms that can't be managed at home, they're moved to the inpatient unit until those symptoms can be managed. It's meant to be short term. Normally it's 24 to 72 hours until we can get that person back home. Again, we try to do everything to avoid that, because most people, when they're in crisis, they don't want to get into an ambulance and travel across town 30 minutes and go to a facility where they don't know anybody, where it's more like a hospital environment. But there is general inpatient care available. We have chosen not to have our own inpatient unit. As I said, we really focus on crisis care, bringing that nurse to your home, to your bedside. But we are contracted with over 30 facilities in the Valley. So if there was no caregiver in the home, if there was some reason the patient didn't want to stay in their home and they want to go to a facility, we have locations throughout the Valley, including Boulder City, where we could say, you know what, my son works in Boulder City. If I could stay out there, it'd be closer to him, he'd be able to visit me more often. So that is an option, and again, if it's medically necessary that someone goes inpatient, it's covered 100% by Medicare. And the final one, which I think is beautiful as well, is called respite care. This is meant for, let's say we've got a caregiver and the patient at home, but something happens. We just actually had a case where the caregiver themselves got sick and had to go into the hospital. We don't want to leave the patient there by themselves. They can be moved for 5 days of respite. This would also be a situation, let's say that caregiver has something wonderful, like you have to go to your grandchild's graduation, or somebody's getting married, or heaven forbid, you have to go to a funeral, but you have to go away. Who's going to take care of your loved one? Medicare will pay for up to 5 days at a respite facility. And you know, we talked about those certification periods. Every certification period, you're eligible for 5 days of respite. Okay, so that's a really wonderful benefit as well. So that's kind of Hospice 101, as we like to call it. I'm going to review some of those key points again, okay? Number one, it's covered 100%. There is no out-of-pocket costs. Hospice is provided wherever you call home. So wherever that patient lives, hospice comes to them. We really focus on living, right? It's not about giving up. It's about focusing on quality of life. We know we can't cure the illness, but we can keep somebody comfortable, manage symptoms, help them deal with everything from spiritual to emotional, so they have the best quality of life with whatever time they have left. And then hospice is not just for the patient, but it's also for the entire extended family, caregivers, whoever's involved in their care, right? Your next slide, I'm not going to read to you, but it says what matters most. I want you to read this. Take just a moment. I think this is true for most of us. We all want more time. I think if you asked any of us, from young to old, we don't want to die. We all want more time. If we could have just a little bit more time. But as we talked about, dying is part of living. And so when it comes to that point, we have to really weigh what's most important. Okay? And the last slide just talks again about how hospice support does not end when the patient dies. That support is available to the family, the caregivers, the loved ones for 13 months after.